Good morning, respected panelists. Myself, Dr. Snehal Rajgire, is going to present the case report on ALPORT syndrome. Huh? 20-year-old male presented by his parents to the OPD with the chief complaints of both eyes diminution of vision, which was gradual, painless, progressive with intermittent headache, vomiting since last 3 months, no redness or ocular pain. The parents also notices impaired hearing and generalized weakness. On further evaluation, he had an episode of hematuria. There was no history of dialysis. Family members were not evaluated for the same. They were not giving any history. Refraction of the both eyes compound myopic astigmatism, regular astigmatism, and keratometry were within the normal limit. On examination, he was conscious oriented, IOP were normal in both eyes. Anterior segment reveals the bilateral clear cornea with the conical protrusion of clear lens, that is anterior lenticonus. Distant direct ophthalmoscopy revealed the oil droplet appearance. On OCT, there was normal foveal contour, and he was found to have the high blood pressure, that is 160 by 110 mmHg. These were the investigation in which the patient showed anemia, serum creat was raised 2.7, and urine analysis shows 35 to 40 RBCs. These were the anterior segment imaging, which reveals the both eyes clear lens protrusion, that is anterior lenticonus. OCT macula were normal both eyes. These were the pentacam imaging. So my provisional diagnosis is ALPORT syndrome. A short info about the ALPORT is the Dr. Cecil ALPORT was the first to describe ALPORT in 1927. It is a progressive familial kidney disease leading to the basement membrane disorder, which is a type 4 collagen. So these type 4 collagen is most important basement membrane found in the cochlea, glomerulus, descent membrane, Bowman's membrane of cornea, anterior capsule of the lens, ILM and the Bruch membrane of the retina. So all these are affected in the ALPORTs. Main gene affecting is the COL4A5 gene, which is an X-linked, most commonly seen in the males, and all the females are the carriers. Alpha 1, total 3 genes are affected, that is 3, 4, 5, which are all present in the Bowman's membrane of the eyes, basement membrane of the eyes, ears, and the GBM. In electron microscopy, we will see the alternate areas of thickening and thinning of the GBM and the splitting of the lamina densa, which will give the basket weaving pattern. 3 ocular manifestations are seen, that is cornea, lens, and retina is affected. In cornea, we will see the PPD, posterior polymorphous dystrophy. In retina, we will see the giant macular hole, which is normal, which is more than the normal. Then dot and flex retinopathy and temporal thinning of the retina. In lens, we will see anterior capsular cataract and anterior lenticonus, which will give the oil droplet appearance. So anterior lenticonus is an anterior lens protrusion through the thinnest capsular area. Cataract can develop as a result of the process of healing of the spontaneous capsular rupture, which appears due to the absence of the COL4A5 gene. Oil droplet is a pathognomic sign which can be seen on slit lamp or IDO or retinoscopy. The myopic shift and abnormal lens shape due to the anterior lenticonus actually lead to the blurry vision. Bilateral sensorineural hearing loss usually appears by the age of 10, which goes parallel to the symptoms, renal symptoms, which are more frequent in the male. We will get the triad of kidney disorder, anterior lenticonus, and sensorineural hearing loss in ALPORT. So this is a short about ALPORT. So finally coming to our discussion. So our patient had all these 3 symptoms, so we suspect ALPORT syndrome. In the view of these classical signs, hearing aid was advised for hearing impairment along with auditory and ENT opinion, nephrologist opinion for kidney biopsy. Decision were taken for clear lens extraction with IOL implantation, but the patient was lost to follow-up. So the conclusion, we report a rare case of ALPORT syndrome. Detailed evaluation and early treatment of these variants are required to improve the quality of life. Early diagnosis is important in order to provide the appropriate multidisciplinary treatment by nephrologist, ENT, and ophthalmologist team. Early intervention can provide a better hearing, leaner, and visual prognosis can provide a better quality of life. Thank you.
We must be seeing the cases of ALPORT syndrome. So, Snehal,
Yes.
that was really nice presentation.
Thank you, ma'am.
So, what was vision in your case?
Vision, 3 by 60 and 2 by 60 almost. Yeah, yeah, cataract and high myopic astigmatism, both eyes, -8. Yeah. Yes, because of anterior lentigonus, that's why there was. Yes, yes.
And what was the cause of renal failure in this patient? Renal failure?
No, patient doesn't have renal failure.
Because the urea is high, creatinine is high, the patient is hypertensive.
Yes, yes, yes.
Was there any hypertensive changes in the retina because of
No, no, no. There was no changes in retina. Retina was totally normal.
the macular hole is there, na?
N- n-
That's one of the you're talking about the macular hole.
Yes, sir. In my presentation, there was nothing in retina. In generalized, I told. Yeah, in generalized, I told that so many findings are there, but our was very rare. Like we don't have any OCT was normal. Usually, temporal thinning of ILM is present. My OCT was normal. Then my fundus were normal. Usually, dot and flex retinopathy is the first early sign, but that was also normal. So actually, we were waiting for kidney biopsy and everything, but a patient didn't come back. So I took it as a e-poster because I don't have much to present in my case. Yeah.
Even the genetic studies could not.
Yes, yes. I didn't have anything, but the three symptoms that renal, that hematuria, hearing impairment, and anterior lentigonus, these were the classical for ALPORTs. Yeah, we don't get this tried in anything else. We get in ALPORTs.
And do you expect any difficulties during your cataract extraction?
Yes, ma'am. We will get two difficulties while making the CCC, capsulorhexis, and while hydrodissection. For hydrodissection, we have to be very gentle because there may be associated posterior lentigonus too, so associated with posterior polar cataract. So we might get the posterior capsular rupture. And while CCC, it tends to run out in the periphery. So we tend to do not start in the center. This is the tip. We have to start from the beyond the cone and try to involve the cone in that flap so it doesn't go out, and we have to maintain the chamber with the visco so that it doesn't go out in the periphery.
I think very nice presentation.
Thank you, sir. Thank you. Thank
We
you.
have learnt a lot from you today.